So hello guys, welcome to this video by BiteSizedMed about long-term oxygen therapy in COPD. So I will be explaining to you what is long-term oxygen therapy, why is it given, to whom is it given, and how is it given. COPD is really bread and butter disease for us physicians, especially GPs and general family medicine doctors, and also internists. So we need to understand concepts in COPD, and I've realized that, including myself, in MBBS, in med school, a lot of people are quite confused. So let me break this topic down for you so that you can remember it, never forget it, and understand it quite well. So what is long-term oxygen therapy? Imagine this: a patient with COPD does not need to be an exacerbation of COPD. So COPD is not just exacerbation. In your wards, the patients whom you see are patients with exacerbation of COPD, but after they get discharged from your wards, it does not mean they have healed from COPD. It just means that they've come out of this exacerbation episode, right? So they do have baseline COPD. So COPD patients who are stable with optimal treatment can still have advanced COPD leading to hypoxemia. So because in long-term oxygen therapy, you can guess that we are trying to give these patients with oxygen supplementation at home. So intuitively you can think who would require long-term oxygen therapy would be that person who, because of his COPD, but may be stable, is experiencing hypoxemia, is experiencing low oxygen levels, right? So any COPD patient who is stable, is on optimal medical management, has come to your OPD just on a follow-up. That is one scenario. Another scenario could be a patient who was admitted to you with acute exacerbation of COPD and is now has recovered off of it. You have assessed the patient and you are planning to discharge him or her. Now, does this patient require long-term oxygen therapy or not? Everything revolves around oxygen. Everything revolves around oxygen. Let me show you how. So the first thing we understand is, in whom do you consider long-term oxygen therapy? So do you go after every COPD patients, try to assess them for long-term oxygen therapy? No. If a patient, see, I've told you, any patient who might have been having a stable disease, might be in optimal medical management, but still in room air his oxygen saturations are less than 92%. If oxygen is low, you would have to give oxygen. But before giving, of course, there's one other step. In this patient, you will assess if this person really needs LTOT or not. Number two, in any patient with very severe COPD, now there is guideline to say what very severe COPD is. According to the GOLD guidelines, if FEV1 of this person is less than 30% of predicted value, that means this patient has very severe COPD and needs to be assessed for LTOT. What does needs to be assessed mean? It means that this patient may or may not require long-term oxygen therapy, but you have to look and see if they really need LTOT or not. Number three is polycythemia. Any COPD patient with polycythemia, you have to assess. Now, why polycythemia? You all know polycythemia is an indirect marker of hypoxia or hypoxemia. Whenever there is low oxygen in the blood, body tries to react by increasing the number of RBCs so that more number of hemoglobin is produced and more oxygen can be taken up from the lungs. So polycythemia, any patient with polycythemia, you have to suspect that this patient might be suffering from hypoxia. Number four, raised JVP and peripheral edema. what do these two things indicate? These two things indicate pulmonary hypertension. Sorry, these two things indicate core pulmonary right-sided heart failure. Because of what? Because of pulmonary hypertension. Because of what? Because of COPD. Now, why did this pulmonary hypertension occur in the first place? It is because of hypoxemic vasoconstriction. Now, please review your physiology. But what happens is when there's hypoxemia in the lungs, there's reactive vasoconstriction. Also, when there is hypercapnia in the lungs, there's reactive vasoconstriction, trying to shunt blood into those areas of the lungs which are functional and can absorb oxygen. So all of these things indicate that there might be low oxygen levels in this person's body. Now, when they fulfill these criteria, then you proceed with the how. So how do you assess? How do you assess for long-term oxygen therapy? You ask this patient to come to your OPD and do an ABG. Then ask him to come to your OPD 3 weeks later and do another ABG. Now again, I've already begun with the assumption that this patient is stable and is on optimal medical management. That is, whatever drugs you've given him or her is controlling the symptoms. It's not causing exacerbations. Okay, so when you do this and when you look at the reports, so whom to offer? So you look at ABG reports and you see that there again everything revolves around oxygen. So their oxygen PO2, partial pressure of oxygen, is less than 7.3. You have to offer them long-term oxygen therapy. If partial pressure of oxygen for them is 7.3 to 8, then you have to look for other signs, any one of polycythemia, again indirect marker, raised GVP, peripheral edema, and pulmonary hypertension. So pulmonary hypertension might be diagnosed not just based on clinical signs but also based on echocardiography findings. So if these patients have a pH value of 7.3 to 8 kilopascals, you would have to offer them with long-term oxygen therapy. What do you do in long-term oxygen therapy? For 15 hours per day, almost around 15 hours per day, you put this patient in oxygen. This is the criteria for whom to assess, how to assess, and whom to offer long-term oxygen therapy in COPD. So I hope this really made it simple for you. If you like this video, please share it with your friends so that everyone understands. COPD is one topic that everyone should know how to manage, and they should understand what is going on with this patient. If you have any questions, please put it in the comment box below, and like, share, and subscribe the video. Thank you for watching and have a good day.